Okay, if you are here for the PRCDA Expansion Study Kickoff meeting, you are in the right place. Jumping right in to the meeting agenda. First and foremost, we have scheduled 90 minutes for today's meeting. We will do our best to be respectful of that time, of your time, and utilize what this time that we have together to the best extent possible, with a focus on discussion. There will be several opportunities to engage throughout today's meeting, and we encourage interruptions for questions and comment as we go through as well. So we'll start by getting to know each other a little bit with introductions. We'll go into a high-level overview of the project. I mentioned that 3 kickoff meetings occurred this week. This is the third of 3, and we'll kind of illustrate what those other kickoff meetings were talking about, so we know that for context. We'll get into the phase purpose. We'll look at a summary of the phase and some critical questions. We'll start a discussion, and we'll use a digital whiteboard to record some of the answers as we go through that. We'll look at a preliminary data request. We'll look at the schedule and what's coming up next. I think timeline is going to be important. It has been important for the previous meetings. And as Mark mentioned, I think it's going to be important for this one too. And then we'll adjourn. So starting with introductions, I would ask Christine to start us off and maybe popcorn for the IHS folks.
Sure. Good morning, everyone. I'm Christine Brennan. I'm the Associate Director of our Office of Public Health, and I am also the Area Statistical Officer. I'll turn it over to Julie to introduce herself.
Good morning. This is Julie Schulte. I'm the Purchase Referred Care consultant for the California area. And I will turn it over to Jonathan Rash.
Good morning, Jonathan Rash, Associate Director for Environmental Health and Engineering, and I will pass the mic to Alex.
Hi, good morning. Ali, Program Manager for Facility Engineering Program in Sacramento, California with Indian Health Service. Thank you.
Is that everybody from IHS?
Yes, it is.
Okay. For the work group, we'll ask name, position, and if you're willing to share a little bit more about how you came to be part of this work group and this planning effort, we'd be interested in knowing more about that too. Mark, you're first up on my list. Would you mind introducing yourself?
Sure, yeah, thank you. Chimisunui, I'm Dr. Mark Lobo. I'm a citizen of the Pitt River Nation from Northern California on my mother's side and Cheyenne River on my father's. I work with the California Rural Indian Health Board, have worked for CRIB for going over 26 years pretty soon. CRIB has a membership of 70 federally recognized tribes across California, rural and frontier regions in particular, and 20 tribal clinic systems also throughout the state. So within that, we do unique work through Indian Self-Determination Act authority and represent a series of tribes in meetings with federal agencies. So in part, it's in that capacity that I'll be dialoguing with federal agents today and likely making some additional recommendations in a government-to-government capacity to work particularly with federal representatives at a later date on this topic.
Thanks, Mark. Orvin, would you mind going next?
Yeah, no problem. My name is Orvin Hansen. I'm the Chief Executive Officer at Indian Health Council, Inc. So Tribal Health Program. Governance is the 9 tribes here in North San Diego County. And along with Julie, Mark LeBeau, and Chris Devers, I sit on the Director's PRC work group. on the national level. So I'm not only here for Indian Health Council, I'm here for all of California. I'm deeply interested as we go through, and as Mark talked about with PRCDA, the tie back to California, tie back to active user counts, a lot of what we've talked about in the past. So really happy to be here today and become engaged in the discussion.
Thank you. Nanette, would you like to go next?
Yeah, Halito, good morning. My name is Nanette Starr. I'm Choctaw from Oklahoma Nation on my father's side, the Yandell family. I am here in the capacity of being the Director of Policy and Planning for the California Consortium of Urban Indian Health. We have 10 urban Indian organizations across the state, and I'm here to help support the work that they do. The PRCDA expansion, potential expansion, has a lot of impact, so I'm here to advocate, learn, and join in on the conversation. Thank you.
And Angel.
My name is Angel Galvez. I'm the CEO at the Bakersfield American Indian Health Project. On my father's side, I'm Tarascon. On my mother's side, I'm Purepecha. The language you just heard is speakers of our language means Tarascon, so we speak the first language of the Purepecha people. We have a very vibrant Purepecha community here in the county of Tulare and the county of Kern. I work in the county of Kern. I've been here about 5 years. I was born and raised in Tulare County. My father grew up in a labor camp. We grew up among the Yoka people. I worked at the tribe for a long time with Tule River Reservation, and then from there I came here. My interest in this, I also serve as a vice president for the National Consortium of Urban Indian Health. We're one among 10 urban Indian healths in California and one of 40 urban Indian health programs in the nation. I've been interested in this work also for a very long time, not only from the lens of working at the Tule River Reservation, but also now working for an urban Indian health. We have one federally recognized tribe that does not have a health center for all natives that reside in the county of Kern. That is the federally recognized tribe is the Tejon Indian tribe. We not only employ Tejon Indian tribal members here, but also our chairwoman, Ms. Jackie Lopez, is a member of the Tejon Indian tribe. So she serves as a great asset to the Urban Indian program and collaborates and communicates with the Tejon Indian tribe on mutual interests. I will popcorn it over to Ms. Oh, sorry, I'll just go back to, sorry about that.
Oh, that's good. Thank you for sharing. I think I just saw Angie join. Angie, would you mind introducing yourself?
Sure. Good morning. My name is Angie Wilson. I'm a Pitt River tribal member and serve on the Pitt River Health Authority Board of Directors for the Pitt River Tribe for our clinics. We got 2 clinics up in our area, and also serve as one of the Northern California tribal representatives for the California Area Tribal Advisory Committee. So appreciate being here today. Sorry I'm running a little bit late at my own medical appointment this morning, so happy to join in. Thank you.
Thanks, Angie. Did I get all of the work group members?
Virginia's here.
Virginia.
Yeah, I'm here.
Go for it.
Squanicoy. Virginia Hedrick, the Executive Director of the California Consortium for Urban Indian Health and a member of the Yurok tribe. And yeah, here to understand how this impacts American Indian Alaska Native people throughout the state of California in both urban and rural settings.
Thank you. Anyone else from the work group? Okay. Excellent. Thank you all so much for introducing yourselves. A little bit about us and our team. This contract is held by the Bodwe Professional Services Group and WBK in particular. But our group is wholly owned by the Pokagon Band of Potawatomi. We are architects, planners, designers, contractors that do work from planning projects, much like this, to all the way through to building projects. In Potawatomi, Bodwe means to light a fire for someone. So that's really indicative of our calling. My name is Alex Hokkanan. I am the Manager of Design Research and Sustainability. And for this project, I am the project manager. Stephanie, do you want to introduce yourself?
Yes, good morning, good afternoon, everyone. Stephanie Sokolowski. I am a studio director at Bodwe Professional Services Group. For this task order, I am the program manager overseeing all of our task orders with IHS on this planning contract. I'm excited to be here and meet you all. Go ahead, Kate.
Hello, I'm Kate Ashford. I'm a project assistant here at Bodwe. I'm going to be helping out with a lot of the technical writing and support for this project.
Anthony or Carmen?
Great. Well, before I jump into this, sorry, I saw that someone else, maybe a work group member, just joined the call. Is it Caesar?
Yes. My name is Caesar. I'm with the California Rural Indian Health Board. Sorry for joining a little bit late.
Welcome.
Thank you. Well, thank you all for being here this morning. I'm Carmen Zamora. I'm with the Innova Group. Innova Group is a healthcare consulting firm that has worked with tribal entities and IHS for over 25 years. And we bring a diverse group of individuals to our firm to understand and help organizations such as yourselves or a specialty regional referral center such as this project to understand who they should be serving, how they should be serving them, and what resources are required for a new facility. We've partnered with Bodwe on this project, and we're excited to help move this forward. I have a healthcare operations background working in an FQHC, and I've been with the Innova Group for about 9 years now. In this capacity, I'll be managing and overseeing the entire project, so all 3 phases, you'll see me pop in and out of meetings. I'll turn it over to Anthony, who has experience specifically about this project, to introduce himself.
Hi, good morning. My name is Anthony Laird. It is a privilege to be with you. I recognize some names, and I have quite a history working with California over the years, in and out, started back in 2004. So great to be with you. I've been with the Innova Group for about 25 years, and most all of my work has been with tribal entities, tribal health entities, or IHS related projects. So good to be with you. Daniel, to start our group off.
Good day to all. It is, as Anthony mentioned, a privilege to be with each and every one of you. My name is Daniel Hay. I am a associate principal with the Innova Group, focused in the financial planning side of the health planning analysis. My entire career of over more than a dozen years has been in the financial planning, and as well alongside the strategies and expansion opportunities that come along with that in private healthcare space. And I will now turn it over to my colleague, Kent Tarbett.
Good morning, this is Kent Tarbett. I'm with the Innova Group. I've had the opportunity to work with just about every group in tribal entity in California. And so I've had association with most of you. I've never done anything with the urban program, so it'll be interesting to work with you as well. I've got 23 years with the Innova Group. Prior to that, I was a hospital CFO. So I have kind of a financial background, but it's going to be a pleasure working with you, and I look forward to it.
Scott?
Yeah, thanks. My name is Scott Spann. I've been with the Innova Group for 3 to 4 years now. I've got over 25 years of healthcare administration up through leadership roles experience both on the public and private healthcare side of things. Done considerable amount of work of just organizing organizations, really structuring and oversight, committee oversight up through the board level. I'll be leading the governance phase of the study. I did a considerable amount with the VA, doing some governance study for them, and really looking forward to the opportunity. Thanks.
And David.
Hello, everyone. It's very nice to meet everyone. My name is David Ayers. I've been with the Innova Group for about 9 years. Held a variety of roles in healthcare for about 20 years. In the time that I've been with the Innova Group, I've worked on a variety of planning engagements to include PJD, PORs, joint ventures, area-wide health services, master plans, capital asset master plans, things of that nature. I come at the work from a data perspective. I have worked with and been challenged by data in Indian country for related to population and PRC, both aspects of this project. For this project, I'll serve as the lead for the population study, and just generally very excited to be part of this unique planning project to help the California natives. So appreciate being here. Thank you.
Haley.
Hi, I'm Haley Ora. I am an associate with the Innova Group, and I'll be here for support and for data analytics.
All right, I think that's everybody from our group. Did I miss anybody?
No, I do just want to add, John Temple is our partner in the Tucson office, and you may be familiar with his name. He did complete a UIO study, I think back in 2022, Anthony, if I'm...
23.
23, I believe, yeah.
So you may be familiar with his name, and then also Sailor Hutton will be helping with another phase of this project, providing analysis support.
Great. So thank you for the opportunity. I'm not going to spend but just a second on this slide. And you've met our larger team, and we've referenced regional planning. This particular phase is very lightly connected to that, okay? But we wanted you to catch the context for our work. We are doing population study, we're doing governance study, various investigative work there relative to regional center, which has been a topic in California on and off for almost 20 years. But this study is a little more focused, a little more unique, and so there will be some interplay, if you will, I think particularly between the population study we're doing and the PRCDA expansion, because we'll be digging pretty deeply to try and get to the right numbers that everyone's comfortable with to move forward in our planning effort for regional care. And I expect some of that investigation to be useful to our study in the PRCDA expansion conversation as well. So this is more contextual than anything else. And I want to give, before we move to the next slide, Christine, is there anything you want to say about this study and any potential relationship or not much relationship at all with the rest of our work over the next year or so?
I mean, as you mentioned, I think, there is some overlap between the population study for the Regional Specialty Center and the PRCDA study, which was one of the reasons when Jonathan and I were talking, we decided to combine them into one contract, just because likely some of the data that is, requested and received for the population study will be applicable to the PRCDA study as well, especially in looking at the population counts in those areas that are currently not part of California's PRCDA.
Okay, thank you so much. So I'm going to turn it over to Daniel and Kent to kind of walk us through an overview of the phase, this particular effort, the PRCDA phase, and just going to hit some of the highlights, and then we're going to get into a discussion. We want to hear from you. Thank you. Daniel, Kent.
Thank you very much, Anthony, for the wonderful transition there. So we want to provide and design a process in which all steps are designed to provide the IHS leadership and the CAPIC working group leadership with comprehensive data to inform policy decisions about potentially expanding healthcare access. And in that, the purchase and referred care delivery area. And so our study will aim to quantify in 3 subphases, but not limited to a detailed PRC analysis, the cost implications of that analysis, and assess impacts on existing service levels in urban Indian organizations, as well as the geographic and eligibility mapping. So in the PRC analysis, we're going to analyze population counts, unmet needs, and medical priority levels, and potentially expanding that the PRCDA regions to the 20 counties that are currently excluded. And so in our cost implication analysis, I apologize, thank you, Alex. We're going to look at calculating, as I mentioned, cost implications and potential service impacts on the current and future American Indian and Alaska Native in both tribal and urban programs. And then in the geographic and eligibility mapping focus of our work, we're going to prepare detailed county level maps and projections on population and PRC eligible individuals. And then a critical element of this, as we can all, I imagine we've all assumed, is identifying the data and using and gathering that data at an appropriate service level or an appropriate level to be able to identify current service gaps, analyze the potential for service improvement with the PRCDA expansion, and just the overall identification of what appropriate data is necessary and how we will go about accessing that data. And before we move forward, I wanted to turn to Kent, my colleague. Is there anything additional that you'd like to add here, Kent? I saw Kent mouth no. I believe he's on mute, but
there we go. No, I don't think there's anything else that I could add to what you said.
And so here we have a potential topics to discuss in a more of a group format. So I'm going to take the mic and now turn it towards you all, those at IHS and at the and CAPIC working group. Love to hear from you, because we can talk all day to you, but the real source of and value in this conversation is going to be your inputs and your considerations. So I open the floor. We can start with that first question. What is most important for you in this phase, the PRCDA expansion and population, and the mapping exercise for an outcome?
And we will be documenting this in a live online whiteboard. And it's been noted that sometimes it can get a bit small. So before we jump over there, I'm going to leave the slides behind for just a minute. In the bottom corner, there is the opportunity to zoom in to that, and we'll have the questions repeated on that as well. So you won't lose them when we move over there. Just give me one moment.
And please don't feel restricted to question number 1. If there's other things you want to speak to or something unrelated to that, we want to give plenty of white space before we roll up our sleeves and get to work. We want to give plenty of white space to you to make sure that we are hearing your concerns and what you're hoping for in this project. So I'm suspicious that you're looking for more than just a report to go on somebody's shelf. So we want it usable and implementable. So what are your thoughts? What are your concerns? What are your hopes? Who will take the floor first?
All right, I'll go. This is Angie.
Thanks, Angie.
And thanks, guys, for this week's meetings. I appreciate it. I would just say this. I think there's a couple of things. I think that, PRC expansion study, we know that this isn't the first state to do this. I think that I think a concern that I have is, just not, just making sure that the tribes understand what this means so that they're not concerned like, oh my gosh, what does this study do to us? I think sometimes there's fear, or we'll hear it, or I'll hear comments being made of, well, if more people are on, I'm going to have less money. They're going to take my money to cover the new people. But I think so. There's a little bit of that. I think that's going to be important on how that's framed with this project. Obviously, the other issue that I think we've been talking about in some of the other work groups that we've been on this week is the data. How we capture that data, what that looks like. So I think a lot of that, those same concerns around data points is going to be important. And I appreciate, Christine, you addressing the issue of combining. Some of this is going to cross over into some of those other projects that we're working on. For Pitt River Health Services, we're operating sometimes at a level 1, sometimes at a level 2, but nothing beyond that, which is alarming. So those are concerns that we have, and that's why that regional specialty care center is so important. I also would just say another concern is we are concerned for members that we have that live in the areas that currently do not have coverage. So we're excited to see that this study is moving forward, so we can look at how the trust responsibility is, really throughout all of California, and that our American Indian, Alaska Native populations have access to care across the board. I would also say that I think there's a lot of concern around just PRC in general. So I think this is a good marker. There's probably going to be some concerns because we have Pitt River tribal members that live in PRC communities that are eligible for PRC that have level 1 need and services, but are yet being denied access to care in those tribal communities. And I think there's some education issues that may be stemming around who's eligible and how those members are to be served. So I think that the number one issue that I hear from a lot of the tribal leaders up in the northern area is the concern about the lack of PRC funding. And again, that's where I think that the numbers and the reporting also come in on what we're seeing. So just in a general sense, just kicking off in kind of the initial questions, those are just some general thoughts. I know that we'll get into more questions as we go, so I'll just come back and address those at that time. But just to kick it off, those are some of the issues that we're looking at. I would also, I'll just leave it there and reserve some other comments for a later time and give the floor to other folks that are on this call. I'm very excited to see the amount of people on this call today.
Can I just ask Angie, and maybe others want to weigh in on this real simple question, high level, are the tribal organizations saying, yeah, PERC expansion sounds great, or no, or tell us more? I mean, I'm just wondering where you think tribal organizations are on this question, or maybe it depends?
I think a couple of things. I think from when we look at it from a tribal perspective, I could tell you that some of the discussion is excited that our members who live in those areas that don't have PRC coverage will have access to those particular services should this expand. So I think there's part of us that we understand that a lot of our tribal members can't live in our service delivery area because there's not enough housing, there's not enough jobs to sustain them. So we've got folks that live outside of our service delivery area. We also have individuals who, so that's one.
All right, I'll chime in really quick, Anthony. It's Orvin. So down south, we do talk a lot. And I think right now, most tribal health program directors are careful and cautious. And I think it's a mix. I think, again, they're looking just straight, as Angie brought up, at their PRC budgets and thinking any expansion into another county would be unfunded, right, on what they would want to do. So I think that it's two-pronged. I think we need to do some education, right, on what a PRCDA expansion would be, how it would do. Again, I can't, just getting information from tribal health programs on their PRC eligibility has been a little tough through the years. A lot of people are close to the vest, right? And I think they are because the lack of funding, and they don't want to admit they're just at, the former level 1 funding. I know Julie's on. I know the federal's gone to the new PRC eligibility matrix. I know my clinic's looking at it and implementing some other areas of it. I don't know where other people are, right? But I think that has to do quite a bit with PRCDA expansion. Just the dollars, the reality of the day-to-day operations, what they're paying out for inpatient care, and just being very careful and cautious as they look at PRCDA expansion. But I think some do understand. But I think we need to get that message out there. It's great, again, to see so many people on this work group. I just wish we had some more tribes involved, or a couple more tribal health program directors on here to hear their take. I firmly believe in this. I want to collaborate, not compete with, at least down my way, with any urban partners that are in those counties. I mean, I'll be glad to say it in here. We have added Orange County to our service area. We're looking at Orange County from the PRCDA side of the shop. I can't speak for other tribes and the other urban counties that aren't in the PRCDA, but I see it as just ongoing development and sustainability of California area funding also all the way through. So
I would agree. I would agree with Orvin. This is Dr. Mark LeBeau at CRIB. There's, a lot of uncertainty among a number of tribal clinic representatives in California, not knowing how will this impact service delivery, how will this impact their funding. IHS provides extremely limited PRC funding to all the tribes in California. So much so that in other IHS areas, they enjoy not only allocations of PRC funding per tribe, but also PRC funding support to those IHS hospitals and compacted IHS hospitals. So there's 2 allocations of PRC money that flows into those other IHS areas that enjoy the delivery of hospitals, either directly administered by IHS or compacted by tribes to deliver those services. So the tribes in California, the tribal clinics, the tribal staff, the tribal families are well aware of the underfunding of PRC in California. It is unfair, actually. There is a judicial ruling on that verifies inequitable funding to California tribes by IHS. PRC is one of those. So, the history here in IHS delivering care, it's underfunded for decades. So, having said that, I am aware that there are 3 areas across the country that are farther along in their process in developing their feasibility study for PRCDA expansion. It's Arizona, North Dakota, South Dakota. I'm also aware that an area was successful in including a footnote in the IHS administrative proposed budget to Congress. It wasn't a dollar amount, but there was a footnote included that referenced the need for additional funding for those additional Indian patients that were included in PRCDA expansion. So there's no new money. So right now, all those regions, Arizona, South Dakota, North Dakota, they can formally expand PRCDA and implement it. But there's no additional enhanced money to serve those folks. So that's a problem they're facing. That's a problem that we are all concerned with also, just because of the lack of resources. But related to those feasibility studies, I know that one should be ready by this month. We're in October now. So there's one feasibility study at least that should be ready for work in North Dakota and South Dakota. And I believe the entity that's assisting in that work is Tribal Health Alliance. So I don't know to what extent, maybe this is a question for our IHS partners and a bit of clarity from IHS, but there's already a method being used in multiple states across the country by another entity. Are we looking at that wheel also, or are we trying to create a wheel here when there may be, feasibility studies that are well down the road? A report will be released in October of this month, unveiling the feasibility of PRCDA expansion in at least 2 states. So for me, you had asked at the beginning, what are your thoughts, and concerns? And so I think for me and the work that we do through CRIB, it'd be helpful to know the method or methodologies that are being utilized by IHS and other areas for PRCDA expansion, and what have they already overcome? What are the challenges that they've identified? What are the barriers, and have they already overcome those so that we don't make those same missteps or have those same challenges? So sort of, I guess, an open question back to our IHS partners on that, and our Innova partners also.
I know I'd love to see those studies, just personally. I'd love to know what's been done.
This is Christine, and I can reach out to headquarters. I knew there were some studies that were happening, but I wasn't aware that they were almost finished. So I will reach out to headquarters to see if we can get a copy of those once they are available.
Yeah, I guess there's an expectation that at least the study in North Dakota and South Dakota, should be completed by the end of October. So if they complete it, maybe it'll take a month or so to finalize it or have tribes review it. I know that in all of this, it really takes a tribe formally requesting PRCDA expansion in order for IHS to engage in that work. It'd be helpful to take a look at those studies. Thank you.
I see Angel's hands up.
Yeah, and Virginia's hand's been up too.
Virginia, okay.
Yep.
Hi, Virginia. Thank you. I'm just giggling. I don't know if I'm not well seen on the screen. Can you scroll to the left so I can see all the questions, because I did have responses and I wanted to just be succinct in them. Okay. So I'm going to start from the bottom up. What concerns I have really are regarding data. So the Indian Health Service already has what I would consider a very flawed data rules book on how they assign patients. So when it comes to reporting workload reports and user populations, those are not created based on where a patient is actually seen. They are reported based on where the individual resides. And so this creates data efficacy issues. And the Indian Health Service consistently is okay with releasing reports that are wrong, that assign patients to places that do not have facilities or where patients are not seen. So that's probably the main concern, is that urban programs maintain their actual counts. I think so. Related to that, success for me looks like improved data for both urban and tribal programs. I'm a member of the largest tribe in California. And the majority of our tribal members live off reservation. So PRCDA expansion for our tribe would have a deep impact, which means the tribal members living in my household don't have access to PRC. And when we travel home and we're on our own reservation where I was born and raised, I don't have access to PRC if an emergency should happen. I also don't have access to Kaiser, which is my health insurance provided in an urban setting. So there are real access challenges for California Indian people. So I think, going back up to what's the most important part in the process and outcome is that we really address data gaps and that we're able to leverage this to increase access for California tribal people. And third, increase dollars to California tribal health programs, which are historically under the level of need. So lots of comments, but that's sort of like the top of mind for me as you ask those three questions.
Yeah, that's understood. Yeah.
I just wanted to maybe add a little bit, and I think Virginia's points are like dead on. One of the requests that I have, and really the interest we have here in the county of Kern, is that, and maybe this scenario that I'll share with you will help put together sort of kind of the request that we hope to see something that's equitable respective to each county in the PRCDA decisions that are made for each county. Our county here in the county of Kern may have similarities to other counties, but I know each county has their own respective uniqueness. And that's really what I want to share, is that, for example, we in the county of Kern, the Bakersfield American Indian Health Project is the only urban Indian health project offering service to diversity of Native Americans that reside in the county of Kern, including members of the federally recognized tribe Tejon. There are 3 other tribes that are not federally recognized, one state recognized, particularly or specifically one of the tribes, Chairman Gomez, who has a very, very good partnership with Bakersfield American Indian Health. They are a eastern foothill tribe. So the Tabadalabal tribe is up in the Kern River Valley, which is about an hour and 15 minutes from the city of Bakersfield up in the foothills. And their members, their members are descendants of the Paiute people and the Yoka people. So their relatives are the Tule River Indian Reservation and the Bishop Paiute. They used to go to the Twayabi Center for dental and other healthcare. Both of these sites are about 2.5 hours away, but they're in different counties. So the county of Kern, for the Tabadalabal people, the closest clinic would be Bakersfield American Indian Health. However, in the winter, the canyon, the roads that lead to the urban Indian Health down here in Bakersfield area, shut down during the winter because of rock slides and landslides. It's just a very dangerous road to travel. So oftentimes, and they wouldn't travel to Bishop because that's a 2.5 hour drive through the Sierra Nevada, which is also closed down due to weather conditions. So their option would be to go to Tule River because it is a much easier route to go to that clinic. But that's a 2.5 hour drive from where their people live respectively. So it really goes back to kind of, okay, so if we're an urban Indian health program, we're the only Indian health program, which for urban Indians, we don't receive any PRCDA. We don't receive any PRC dollars. This becomes sort of kind of a question where those numbers of the folks we see here at the Urban Indian Health Clinic get assigned to to the Tejon Indian tribe, right? Because they're the only federally recognized tribe, which does have a PRC program for their members. So I think for us, really, the hope is that, you know, we see something that's equitable for the tribes as well as for the urban programs. And perhaps, you know, even, you know, we're probably in a good position that we have our chairwoman, who's the chairwoman of the board of directors for the Urban Indian Health Program, who is a member of the tribe and has, you know, can liaison between the tribe if the council would choose to allow that. So if we became sort of kind of a, a sample county project, this could be an interesting way of really demonstrating the equitable approach to how this sort of kind of benefits or not, or improves the PRCDA for this region, for this county, or if it enters into multiple counties. So I hope that information, unfortunately I have to jump off at 10, but I hope that information, maybe from that information, answers a few of these areas that you have on the slides. And thank you for the time. Appreciate it.
Anthony, you're on mute.
I was just going to say thank you very much for your comment and input and your time here. Appreciate it.
Kent, I see you have your hand up. Would you like to comment?
Yes, the thing I was worried about as Angel was talking, and he says making it equitable from county to county, is the cost structures in the different counties in California. For instance, the cost of care in Orange County, LA County, Riverside County is going to be a lot different than the cost in Sacramento County, Yellow County, or El Dorado County. So to make it equitable, how far will those funds go is kind of hard within the state of California, because we know that California is almost like two states in one.
Yeah, I think these definitely are some of the challenges for sure, right? Because cost of living and cost of care is different in county to county. What's not different though is the reimbursement rate. And I think that for urban Indian health programs, and we all know this, the tribes, you know, FMAP rate is a reimbursement rate that's equitable across the board for all tribes across California. However, for urbans, it's not. For urbans, we have to negotiate a PPS rate. We don't get the FMAP rate. And, you know, oftentimes urban Indian centers have a very low rate of reimbursement. So again, I think this is where the challenge is for us in sustaining some of our programs, because in some tribes perhaps, and I don't want to speak for tribes because I don't work for a 638 program. But in my experience, when I was working for a 638 program, a percentage of that reimbursement rate would go back to, say, healthcare for the members, right? So it's a helpful way of really sustaining costs for care. But for the urbans, we're sort of kind of struggling with that because we unfortunately don't have enough reimbursement to really kind of spread out for client services. So putting these dollars back into the community of Indians we serve is very difficult because we obviously don't get a competitive rate.
Orban?
Yeah, I'm much like Angel, I got to leave at 10, so I just want to get a few more words in before I have to leave. So just important to keep within the work group's guidelines is once we do get the PRCDA reports from those other states are a mixture of ITNU with a lot of I in there on some federal hospitals and inpatient facilities. Remember,
True.
California is just T&U. So
Right.
we need to look at those reports, but we need to look with our eyes wide open on the T side. Want to speak a little bit on what Virginia brought up too. Almost, if you start looking, we're California, we still have Title I contracts, but it's a majority of Title V self-governance compacts throughout the state, which is a blessing and a challenge, right? So we have the same thing down in our area, and I'll just speak for IHC. I'm not going to speak for anybody else because that's where I work. So quite a few enrolled tribal members that are out of our PRCDA for Indian Health Council, right? So just to look at ways to start talking about a statewide PRCDA would be, you could still, at least that would be a start of coverage all the way through of getting folks into the system. So I just wanted to bring up that challenge, but getting back to solutions, anything we can do on working through IHS or working through, more importantly on my side, through the tribal health programs on increasing data and increasing good data. I know I can share, we've had, and Christine knows as well, we talk a lot, and I think I'm just going to speak for our clinic. We go out of our way. We want to get good data all the way through to NDW and other areas on active users, PRC, and what's going on. And it's a tough road. So just working, I think one of the solutions I'd love to see is California, is what I brought up before, is at least for working through, and I'm not talking, because I understand urbans don't have PRC funding, but there's other data issues that can work on us with, is just to make sure we have that talk on the importance and to me, the priority of having good data as we move forward on PRCDA expansion and others. So thanks for taking the time to listen.
Thank you, Orphan. Appreciate it very much.
And I think, oh, did Oregon just leave?
Yeah.
I was just going to say before others leave, we will be sending a data request out that you can begin to look at to help us think about how we can obtain that data directly from the sites, so that it's your data and it speaks to what you're seeing and how you're serving these populations.
Anybody else? Any other input, hopes, outcomes, concerns about process, concerns on the front end? All right, quiet group, thoughtful but quiet. If there's nothing else, I guess we can move on. Just one final opportunity. Anybody else have anything they want to share? Okay, all right, thank you. We can head toward that next slide, I think, then.
Get us right there.
So you'll
Right,
see
so-
here. I
Go ahead,
apologize.
Daniel. Go ahead. Go ahead, Daniel.
You'll see here we'll be, as Carmen mentioned, we will be sending out and sharing with you all a data request list, and we've created data request lists, specific requests for a number of the organizations that are represented on this call and within this that we hope to hear from in this study. So California area IHS, we have the IHS headquarters, urban Indian organizations, and tribal health organizations within the state of California. And we did that because we know that we believe there are very important data that each hold, and we want to make sure that your organization is focused on the data that you all have and are able to share with us And you'll see that there are a number of data requests, and we would look for, and I want to initiate and put this out here that the Innova Group, Bodwe are available for consultation if you have questions on what the data might be asking for. It is a large data request, and there's a number of aspects to it that will take some time to gather. So look, Chair Anthony, is there anything additional on your end that you'd like to share on the data request specifically?
Just a couple thoughts. Christine, are you the data POC? Do we send stuff through you? Are you the receiver of data coming in for this phase? Who's the appropriate person?
Yes, I'll be the point of contact for the PRCDA study.
Okay, thank you. I guess the only thing I would maybe stress here is to work group members is what you see on the screen is not the complete data request. Okay, it's just a snippet. We'll send you the complete draft data request, just the list, just the checklist. We're not going to go into the weeds, but again, just to be clear, to try and be clear, what we're looking for from you will be any feedback you can provide on, yes, we think that's a good data set to go after. No, don't bother with that. It's a dead end. You're going to find that's a dead end. Or maybe I don't see how that data is going to bear in on the study. Maybe that's some feedback. Or your team should think about this other source of data. If you haven't thought about it, here's a source that we think would be particularly productive, helpful. So we're not asking for you to roll up your sleeves and do any work on the data yet. We'd like to make you partners in identifying, refining what data we should be asking for. Any feedback would be helpful. When we get that back from you, we'll review that, edit the data request accordingly, and we'll review that with AREA as well. And then we'll send it back out and say, okay, now let's get going. Let's pull the data in, go after it. And so as Daniel alluded to, some of that may be work for the THOs, some of it may be work for the urban program, some of it may be unrelated, may go to somebody else, a data source at IHS or a data source at the NDW. Does that make sense? Okay, all right.
Could I also add, Anthony, that we'd also like to know any of the pitfalls that you might know that exist in some of the data we're going to receive, so that we understand it better and how reliable it is.
I think we concur, okay, from our experience, we concur that PRC data is difficult. It's difficult to get an accurate picture for a variety of reasons. So any help, perspective you can provide would be appreciated. And Daniel, are you handling this or am I handling? Do you know? Can't remember.
You're welcome to continue, Anthony.
Okay, so next steps here, again, we're going to send the data request checklist out to you, give you a chance to review it, comment, suggest any additions or deletions, and just send that back to Christine. We're targeting getting this part wrapped up pretty quickly. We'll see. We want to review our checklist before we send it out to you based upon some things we've heard in each of the meetings. We want to make sure it makes as much sense as it can make before we put it in your hands. So the data request, we'll update it after we hear back from you, and then we'll send that back out. And then that'll be distributed through the area point of contact, which will be Christine. And hopefully we can get data back early November. We'll see. getting good data, in our experience, is the most challenging part of most projects that need to be data-driven. And I think data needs to play a significant part here. So this is important. We want to get to the end, but we want to make sure we're hearing from the folks and from the sources that we need to hear from to get there, so that everybody comes along together. And at the end of the day, at the end of the report, we can all look at each other and say, you know, it's a good report. It's a good representation of what the need is, what we think the impact is going to be, and we're supportive of that. So we want to get there together. Alex?
Thanks, Anthony. I jumped over this slide because it seemed like you were on your way, and I felt like the bullets would support that discussion. So I think zooming out then after that, just to look at the entirety of the phase schedule. Anthony mentioned at the top that we're anticipating this is going to take about a year, and a good chunk of that time is dedicated to figuring out the data and making sure that we have the best possible sources of information before getting into that report writing. So that's what this is to illustrate. More details are included in the handout as well that was sent over this morning. So I encourage you to take a look at the full schedule. That would include all of the phases. You can see how they overlap and really talk to each other as well, or don't talk to each other, as the case may be. And this is the contact information. I assume most of you, if not all of you, have Christine's, but ours are here as well.
So thank you, everyone. And I think, Alex, if you have nothing else, or Carmen, you have nothing else, we'll turn it back over to Christine. If you have any final words before we let you go.
No final words. I'll just reiterate what was said at the beginning, is that I will make sure everyone gets a copy of the meeting notes and the recording once those become available from Anthony and his team. And I will also send out the questions that they would like feedback on for the data collection once I receive that as well. So I thank you all for attending today. We really appreciate all of your feedback.